Hello, everyone. I'm Siri Vaith, Executive Director of the Cystic Fibrosis Research Institute, or CFRI, and I welcome you to what will be a very interesting podcast on medical trauma. Before we get started, a bit of housekeeping. Please note that the information and insights shared during this webinar should not be used for medical diagnosis or treatment. And as always, please consult with your care team before making any changes to your health management plan. I also want to thank our sponsors whose support has made this webinar possible. These include Vertex Pharmaceuticals, Gilead Sciences, and Viatris. Thank you so much. For those attending the webinar, you can put your questions in the Q&A box, and I do ask, please not in the chat, in the Q&A box, and Kate will try to respond to them either throughout or after. We're going to play this by ear, her presentation. So at our National CF Education Conference last summer, Kate Yablonsky presented on medical trauma. And obviously this is a topic that impacts many members of our community, but has historically not been well recognized or addressed. And her presentation at the conference was extremely rich, and I encourage you to go to CFRI's YouTube channel to watch the recording of that presentation. But sadly, that day we ran out of time before Kate could do a deeper dive on the therapeutic strategies that have been proven to be effective in treating medical trauma. And so we are so honored that Kate is sharing her time today to expand our knowledge. And for those of you who do not know Kate Yablonsky, a bit about her. Kate joined the adult CF team at Stanford in 2018, where she is also the social worker for the interstitial lung disease program. Prior to that, she worked with the pediatric oncology and stem cell transplant teams at Lucile Packard Children's Hospital, also at Stanford. Kate earned her master's in social work from UC Berkeley with a concentration in health and is a licensed clinical social worker. In her spare time, which I'm sure is kind of a joke to say that because I don't know how you have spare time, Kate, she facilitates CFRI support groups for adults with CF, our pediatric CF caregiver support group, and a support group for adult CF caregivers and spouses. She always gives generously of her time, and I do want to share, she was recently recognized by the national CF community as CFRI's 2024 Cystic Fibrosis Professional of the Year. So well deserved. Welcome, Kate.
Thank you. Thank you, Siri. Thank you for the wonderful introduction, and thank you for having me. As Siri mentioned, I gave a version of this talk at the CFRI conference this year, and it seemed to really resonate with people, particularly the people in the audience that had CF, which is not surprising, but I'm really glad that we have more time today to dig into some of the things that I had to rush through because the time was limited. So this is a topic that's very close to my heart. I have my own experiences with secondary/vicarious trauma that I experienced from my previous role as a pediatric oncology social worker. Even though it's not apples to apples, you'll see as I continue to talk about this that there's a lot of similarities in varied trauma experiences. So I've had to spend a lot of time thinking about this and figuring out how to heal myself. So when Siri asked me originally to speak at the conference, without having any prior knowledge that I had this personal connection to the topic, it really felt fated and meant to be. And so I knew I had to say yes, even though I'm really not into public speaking, but Siri is helping me do some exposure therapy to that. So we will talk more about that later. And, the other thing that is really nice to think about for me personally is that one of the ways that people move on from and integrate the trauma they've experienced in their lives is by making meaning out of it and paying it forward. And this is an opportunity for me to do that. So I'm really grateful for that. So thank you to CFRI and to Siri for that opportunity. And I want to always give a trigger warning. Anytime we're talking about trauma, you can often be surprised by what might come up for you. So I encourage you to take care of yourself as you're watching this. If you need to take breaks or sign off or pause or whatever it may be, don't worry about it. This as opposed to the conference, I can't really tell. So it wouldn't hurt my feelings if I could see you, but I can't see you. So don't worry, it's definitely not going to hurt my feelings. So I am going to share. Oh, the host disabled screen sharing. Do you want to bring up my slides for me, Siri?
I am so sorry. I those away because I thought that you had.
Oh, wait, no, now it's enabled. Mary must have done it.
There we go. Thank you.
Mary's a
Sorry
hero.
about that. Sorry, everyone.
No worries. All right, here we go. Okay, hoping you can see the slides. Everything looks okay. Siri, all good?
It is perfect.
Okay, wonderful. So anytime we talk about trauma, I think it's helpful to sort of touch down on PTSD, which is the post-traumatic stress disorder. This is the slide here has a summary of the DSM criteria. A lot of people are familiar with PTSD. It's sort of in the zeitgeist. People have heard about it and are familiar with it. And in summary, after exposure to a traumatic event, someone can experience lots of different symptoms, intrusive memories, flashbacks, avoidance of triggers, intense emotions, exaggerated startle response, etc. So, not everybody who is impacted by a traumatic experience develops PTSD in terms of the clinical criteria. But even if you don't meet the clinical criteria for PTSD, you still may be suffering from the effects of a trauma and may benefit from help and support. So that's just something to keep in mind. So medical traumatic stress is being talked about more as a distinct experience of trauma because it has sort of unique characteristics. And medical traumatic stress refers to like the psychological, physiological responses to pain, injury, medical experiences, life-threatening events, things having to do with the medical world. And medical traumatic stress is not a DSM diagnosis, but it basically describes the same symptoms as PTSD, but with the traumatic event being some sort of medical thing. And you might be thinking like, why is there a different definition for something that's almost identical to PTSD? But the reason that we're talking about it as its own phenomenon, well, there's lots of reasons, but one of the important things to think about is that people who have experienced medical traumatic stress, that is associated with decreased adherence to medication and medical recommendations, and also reduced quality of life. So this is affecting people with chronic illness and other medical issues. So, like I mentioned, not everyone who experiences a trauma will develop PTSD. The same is true with medical trauma. So the percentages of people that are exposed to some sort of medical traumatic event and develop PTSD are similar to the numbers of people that develop PTSD for any kind of trauma. So for any kind of trauma, it's around like 15 to 24% of people will develop PTSD. In medical trauma, it's about 12 to 25, so similar. And very interestingly, not surprisingly at all, as someone who worked in pediatrics, the numbers for parents whose children are exposed to some sort of medical traumatic event of some kind, their numbers are higher. 20 to 30% of them develop PTSD. And this really did not shock me at all when I saw these numbers. Having worked in peds, there's not a single parent that I worked with that wouldn't have traded places with their child in an instant. Being a parent myself, I think I can say like with confidence, I think watching your child suffer is one of the worst things that somebody can go through. So not surprised at all that parents experience PTSD at higher rates than actual survivors of life-threatening medical events. And then there was a really interesting Brazilian study that was specific to CF and medical trauma. And the numbers they found ranged from about like 7 to 20% of people with CF experiencing some type of PTSD. And the range that they included what they called partial PTSD. So not all of the criteria of PTSD, but some of them. And so that was a little bit more inclusive. So it went down, from 7 to 20%. So there isn't as much research specific to CF and medical trauma because obviously we're a small population and most of the research has been done in cancer patients and heart disease because there's just more of those people to study. But I think one of the really important things to keep in mind in the CF community is that people with a history of trauma of any kind, not just medical, sexual, combat, like any kind of trauma, are at higher risk of experiencing medical care as traumatic. So, we have people with CF in our community that have other kinds of trauma histories, and those people are at higher risk of experiencing medical care as traumatic. And it makes sense if you think about, an example of a survivor of a sexual assault has a higher likelihood of experiencing a routine pelvic exam as very traumatic. So it makes sense, and it's something for us to keep in mind. So we certainly owe a large debt of gratitude to the military population for really leading the way on studying PTSD and trauma, and figuring out what works in terms of treatment. But interestingly, there are more survivors of medical events than survivors of military combat, just like talking about numbers in general. And if you think about the differences between experiencing a medical trauma versus like a combat trauma or some other kind of trauma, the source of threat when you're experiencing a medical trauma is within your body. It's from inside. It's not someone that's going to bomb you or shoot you. It's your own body. And the re-experiencing symptoms that people experience is it's more focused on like your disease getting worse or your cancer coming back, or having some sort of turning point in your ability to function in your life. And one of the studies that I referenced in this talk had a quote that just really stuck with me, which is that medical traumas are rarely discrete events with a defined endpoint. So, for someone that has survived a trauma, for example, like a sexual assault, that happened to them one time, and then of course it sticks with them for a long time. But someone experiencing a medical trauma, there's no end. There's no end to having CF. There's no end to, being in the medical world and being exposed to the things that are traumatic. So that really is a big difference that we have to keep in mind for our people. But people that experience trauma have a lot in common, no matter what caused it. The symptoms are practically identical across the board, no matter what you experienced as traumatic. And really what underlies everything is the through line is a fear of mortality, which is just, a deeply human thing. So for people with CF, this is not an exhaustive list, but some of the common things that people experience that might be traumatic for them. Diagnosis, I think anytime you're diagnosed, whether it's an infancy, as an adult, somewhere in the middle, the diagnosis experience can be very traumatic. It's a life-altering event that shifts your perspective. There's a lot of fear and uncertainty involved. So diagnosis in and of itself, something that everyone has experienced, whether or not they remember it. If you don't remember it, your parents do, and they were probably traumatized. So diagnosis is a big one. Delayed diagnosis is a big one too, especially as we have more and more adult diagnosis or late diagnosis of CF in our community, as we understand more about the different phenotypes and the different mutations. Those people are coming to us with years and years of experience of not being believed in the medical environment, feeling gaslit by providers, being told that what they're experiencing isn't real, being told that they're overreacting, and it really kind of interferes with your ability to trust your own instincts and your own body. And that can be experienced as very traumatic and really stick with people, and have them, when they get to us as a CF team, already be very traumatized and have a difficult time trusting the medical environment. So it's really important to keep that in mind. And then especially for kids, hospitalizations, needle pokes, things that are painful, those are all can be experienced as traumatic. Hemoptysis is kind of the classic, I think, that lay people can understand, like people outside the CF community. Coughing up blood is sort of like a visceral thing. It's very scary to look at. It's scary for it to happen to you. And then, something that seems kind of benign, like mucomist. I have a patient who has like a physical and psychological reaction when she smells mucomist, because the taste is so bad, her body and her mind are like rejecting it, that's like something that like a medical provider would probably never understand, when they're just like, it's time for your mucomist, that it could be this big psychological thing for somebody. Enemas, if a CF enema that's done without care and dignity can be experienced very traumatically. And then anything having to do with surgery, lung transplant, intubation, being in the ICU, there's something called ICU psychosis, which, when I first learned about it as a baby social worker, it was like, it knocked me off out of my socks, like thinking that you could develop psychotic symptoms with no history just from being in the ICU. Like, it really just blew me away, and so anyone who spent time in an ICU or been intubated, a lot of people have stories about how scary that was, and have that trauma lives in their bodies for sure. Discrimination in the healthcare system is a very powerful source of trauma, especially for our communities of color that have spent all their lives interacting with a healthcare system that discriminates against them, and they have worse health outcomes in. And within that, negative interactions with medical providers not being believed. I work with a patient, a Black woman who, every time she has to go into the emergency room, she has a trauma response because she's had so many negative experiences meeting providers that don't know her and don't know her history and the complexities of her chronic illness. And, something that would be routine going to the emergency room for her is a trauma experience. And then, there's the secondary trauma of, being in a healthcare setting. You see a lot of upsetting things in a hospital. And then, being a part of the CF community, especially our people that are in midlife and have lived through a lot of different phases of how CF is cared for and have lost a lot of people along the way, that compounded grief, it can be very, very traumatic. So one of the few studies that is specific to medical trauma and CF was done by our colleagues at UCSF and Kentucky Children's. It's a really, really good study. I highly recommend it. It's in my reference list. They interviewed people with CF who experienced medical traumatic stress, and they found these 3 overarching themes that I think will resonate for anybody on the call. For our community. So the first one is sort of the more straightforward one that you would think, the perceived threat of bodily harm. So threat to your life, experiencing pain, those kinds of things. The other 2 themes may be not thought about as much in other kinds of trauma. One is the loss of agency, feeling disempowered. So if you think about the lack of control that you have during a medical encounter, there's a power imbalance, and the providers have access to your life-saving medication, those kinds of things. The lack of control over your health and what happens with your disease. None of that really is in anyone's control. I mean, everyone can do the best they can with their therapies, but ultimately it's not in your control. And then this last one, I think, is really undervalued, or that's not the right word. Like, we don't think about it enough, or it doesn't get enough credit for how awful it is, which is the lack of control over systems. And that can look like a lot of different things. Most CF centers are part of a large academic medical center, which is a huge bureaucracy. Bureaucracies are dehumanizing by nature, and interacting with a giant bureaucracy can be very disempowering and frustrating. And then the insurance industry. So I don't have to if you're on this call, I don't have to tell you how difficult it is to work with insurances. And people with CF have to do this over and over and over again. Get on the phone, have your life-saving medications denied for no reason. This person didn't talk to this person, and then this paperwork got misplaced, and now you don't have access to the thing that makes your life better, and the robot on the phone doesn't care. I mean, it's so dehumanizing. And people with CF just have to do this so often that we really do have people having sort of trauma responses to this kind of thing. And then the last one is really interesting and really profound, and I think existential in a lot of ways, which is the triggered shifts in identity that these trauma things can bring up. And that involves, shifting back and forth between your perceiving yourself as a well person versus a sick person, and back and forth. So, and we've seen a lot of this in the modulator era, people that sort of perceived themselves as a sick person and then had a new lease on life with Trikafta or a modulator and hadn't planned to live a long life. And we really saw a lot of existential crises during that time. As much as people were, of course, grateful, it really is a huge psychological lift to try to shift how you see yourself and what you think your expectations are for your life. And then the same in reverse. If you've been stable for a while and something happens and you think like, oh, am I now not as well as I used to be? Is this a big change? Like maybe getting a diagnosis of CF-related diabetes shifts your perception. Oh, I'm not this like healthy person with CF anymore. And people with CF can kind of experience that over and over throughout their lives. So I think this is really important. So it's got its own slide. This kind of trauma is really just not validated by our culture. I've talked to so many people with CF, and it's difficult to be a person with CF with as much as they interact with the medical system and never have a negative experience. It's just too many encounters. It's impossible for them all to be good and positive and never traumatic. So whenever I talk to people with CF about this, there's just this kind of shrugging acceptance. Like, this is how it is. This is what we have to deal with. it's sort of out of our control. And that's very adaptive, honestly, to just sort of, try to be accepting of it. But just because we know it happens and that it's going to keep happening doesn't mean that it isn't trauma, and it still matters. So if you saw my talk at the conference, this is a new edition. A very generous man with CF shared this with me and gave me permission to include it in the webinar today. So this is a 55-year-old male with CF. He was diagnosed at birth. He had a double lung transplant about 20 years ago. And he went through this exercise of writing out every sort of medical experience thing that he had gone through throughout his life, all in one place. And he shared it with me, and we were kind of reflecting on it. And he was like, "What's your first reaction?" I was like, "Overwhelm, absolute overwhelm." So I just want to give this a minute so we can all sit with this. I'm going to go through the highlights. And I want you to think about this as I'm going through it with a lens of medical trauma. 278 blood draws, 100 IVs, 250 x-rays, over 29,000 shots of different kinds, 51 scans, 10 surgeries, 35 hospitalizations, 10 out of 10 pain incidents, 78 procedures, 57 pills every day, over 16,000 nebulizer treatments, over 1,200 days of antibiotics, and 4 life-threatening incidents. And then at the bottom, I included this because I think it's amazing. He put, "I think I'm my own hero." So, this is just kind of a great example of what people with CF go through and what they have to sort of learn to tolerate compared to a person without a chronic illness who has never had maybe has had none of these experiences, or only a few, or maybe a few shots, maybe a flu shot every year. It really is overwhelming. And I feel like this puts things into perspective. I do want to say, I think this is a great exercise to do. If in the right context, I think, it's very individual. If this is something you want to do, I think it could be very therapeutic, but really think about for yourself, is this something that you would want to do with the support of a therapist? Because again, this might bring up things for you that you're not aware of, and it might hit you sideways and be more difficult to look at than you predict. So just think about that. But if you are working with a therapist and you feel like this could be helpful for you, I think that this is a really powerful exercise. So if you're worried about yourself, or someone you love, that you might be having sort of negative impacts of medical trauma, these are some things that you can look for. Obviously not exhaustive, but just like to give you an idea of what you might see. So, the classic sort of PTSD thing, the intrusive thoughts. For people with medical trauma, a lot of times the intrusive thoughts are around disease progression, things like that. Avoidance, the way that looks in our population, sometimes it's avoiding going to clinic, avoiding taking medications. There was a study on stroke survivors with PTSD, and the people that had PTSD were 3 times more likely not to take their medications, which is interesting. And then PFTs. I have a few patients actually, but one that I'll use an example, that gets extreme anxiety prior to a PFT. And she is stable. But she has had, especially pre-Trikafta, has had so many experiences of blowing a bad PFT, lower of PFT, that has resulted in, do you have to go to the hospital? What happens to you when you're in the hospital? Is this, the representation of a new baseline? Is your baseline now lower than it was before? Is my disease progressing, et cetera, et cetera, et cetera? So even though now she is very stable and has no logical reason to think that she might blow a PFT that is going to end up, have her end up in the hospital or something like that, she still has a physical and psychological reaction to getting a routine PFT. That's definitely medical trauma. So, being irritable, difficulty sleeping, reckless behavior, germophobia, I have to, spend a little time on, because obviously in the CF community, there is an amount of germophobia that's totally reasonable and appropriate and safe. But in the context of trauma, we're talking about really beyond the reasonable level of protecting yourself, like really like limiting your life in ways, changing your life around because of fear of germs. So the hypervigilance that you see with PTSD, with CF or chronic illness, can often look like symptom panic, like a small symptom that may or may not be a big deal, and you immediately go to the worst case scenario constantly. That might be a sign that you are dealing with medical trauma. Death-related thoughts that you can't suppress, nightmares, being really reactive, survivor's guilt, which is, I think, a pretty common phenomenon in our community, especially, parents and siblings experience this. And then obviously people with CF that have survived their friends that have died from CF, or even people that have access to modulators feeling survivor's guilt for the people that don't. So experiencing panic attacks, abandonment, obsessive worry about safety of family members. There's a quote from one of these articles that I really like, and I think will be relatable to people on this call, which is that your nervous system doesn't have a concept of time. So your body doesn't care how long ago it happened. It's going to react to the trigger like it happened yesterday. So please keep that in mind, because I think there's a lot of shoulds that we hear in terms of these kinds of experiences. Well, that was 10 years ago, or that was months ago. Why? You should be over it. That's not how your body and your brain works. It's just not how it works. And then just a quick note on these symptoms, if you're experiencing any of these symptoms, it doesn't mean that you're broken. These are actually healthy, they're adaptations that your brain used to help you survive. And that's a good thing. And then the decision that you have to make, and the question you have to ask yourself is, are these adaptations in your brain still working for you? And if they're not, and if they are interfering with your ability to live the life that you want to live, then that might be a sign that it's a time to get some help. And there are ways to change your brain's automatic responses. So the thing about trauma, I sort of feel like it has like its own distinct flavor in the mental health world, in that it's an emotional and very, very much a physical experience. So many of you have probably heard of this book, The Body Keeps the Score by Bessel van der Kolk. It's a great book. It is pretty clinical. It goes into a lot of fascinating science with a lot of chapters on brain scans. So if you're into brain scans, this is the book for you, for sure. And it's all about how trauma is expressed through physical symptoms and brain chemistry. So definitely, I recommend it with a caveat. Like, it can be pretty dry at times, and it is very clinical. It's not designed for a layperson audience, but I know a lot of non-clinical people that have read it and benefited from it. But I also have to give you a trigger warning. There's some really difficult stories in there. And like pretty early on in the book, there's a pretty visceral sexual assault story. So just go into it knowing that that is a part of it. But basically, the concept in this book is that we experience traumas in our bodies, whether or not we know we are. We store things in there, and it's not always easy to verbalize it or access it, and we're not even aware of what we're holding. And I experienced this personally in trying to deal with my own trauma. I was like, I know I need to be in therapy, but I would sit down, and I'm a mental health provider. I'm pro therapy. It's not like I struggle with the idea of talking about my feelings. But I would sit down with my therapist and I would have no idea where to begin. Like, how do I start? Where do I, I felt totally lost. Like, I knew I had something to process, but I didn't know where it was, or how to access it. And I've seen this with my colleagues and with my patients. I'll share a few examples. I had a coworker at Lucille Packard who got this mass in her neck, and I'll fast forward to the end. She got it worked up, and it was basically a stress tumor. That's what we colloquially called it. Her body had just like created this inflammation in her neck, all from stress. And I had another colleague who had like major GI issues that completely resolved when she left the job. So like our body is doing something with this stress, whether or not we know it. Our body is doing something with it, and at a subconscious level. And these traumatic experiences have the capacity to literally rewrite our brains. And the sort of classic example of this that a lot of mental health providers are familiar with is children that witness domestic violence in their formative years. When you scan their brains as adults, their brain structure is actually different than others, and their brains are primed to react to everything as fight or flight. So these experiences make literal physical changes in our body, and the treatment for them has to take that into account. So just sitting down and trying to talk about your trauma with a therapist without sort of a trauma lens is not going to work for everybody. It may work for some people, which is fantastic, but if you're like me, it might not be that simple, and you have to kind of come at it from a different angle. So how do we do that? How do we heal? So these are some places to start. Certainly not an exhaustive list, but just to be upfront about my bias, these are my favorites. The three modalities that we're going to talk about are my favorites. And I'll just give a sort of a brief overview of these different forms of therapy that are focused on trauma. So the first one is my favorite, which is EMDR, eye movement desensitization and reprocessing. And it's a very research supported type of therapy. There's a lot of evidence that supports its efficacy. The whole concept of EMDR is that you can recover from trauma without having to necessarily talk at length about the experiences. And it uses something called bilateral stimulation, which stimulates both sides of your brain as you're processing the memories. And the ways that the therapists do that is either through eye movements, tapping, or auditory tones. So sometimes when you'll hear people talk about EMDR, you'll see them do like this with their fingers, and that is part of the bilateral stimulation. But I have to say, I am not an EMDR practitioner. I know this slide is a big no-no, but when I try to explain EMDR, I'm really not that good at it because I don't practice it myself. I just have like an outsider's understanding of what the therapy is like. And when I went on to EMDR International, they had this nice little paragraph that I feel like if you take the time to read this, you have a better idea of what it's all about. I'm not going to read it to you, but because this is recorded, people can pause and read it, or you can go to EMDR International and read it. And basically, the whole idea is that you're decreasing your body and brain's immediate reaction to go into fight or flight. So an example of an EMDR session, or, multiple sessions, because sometimes the stuff doesn't happen all in one session, just to give you an idea of what it's like. And you'll see a lot of similarities in the structure of the sessions of the different kinds of therapy I'm going to talk about today. There's a lot of overlap. So, the first step is always history taking. The therapist learns about your history, identifies the memories that are causing the distress. You do preparation where you learn some techniques to manage whatever's going to come up while you're doing the treatment. Then you do the actual desensitization where you focus on the memory and you do the bilateral stimulation. The whole idea is that this helps your brain process the memory in a different way. Then you do the reprocessing. You connect that memory with positive thoughts, helping with a shift in perspective. And then, usually you end in a body scan, something like that, which is important. A lot of trauma work is a lot of body awareness because of what we talked about with the, body keeps the score. And then, usually you do some sort of relaxation exercise at the end so that you can transition into, back into life. A little bit of a tangent, but I can't help myself because this is just so interesting. As just a side note on Tetris and PTSD. So the Journal of Psychiatry and Neuroscience has an article that's in my reference list if you're interested. They did a study on males who had experienced combat-related PTSD. So, it's not medical trauma, but just interesting. There were two groups. Both of the groups got EMDR. One of the groups got just therapy with EMDR, and one of the groups got EMDR and they played Tetris. And the people who played Tetris actually did better and had more of a reduction in symptoms. And the study noted that they had increased hippocampal volume, which I don't know what the significance of that is or what it means, but apparently it was like a cool thing. And the people that played Tetris had less symptoms of PTSD, anxiety, and depression. So this just goes back to there's something about the brain, the visual spatial of it all, that I think there's a lot more that we can learn and understand about our brains and how they process trauma. So this is from the EMDR International website, just some questions that you can ask a therapist if you're interested in EMDR. And I want to give a shout out to Rachel Grimes, who is actually on this webinar. I did not know she was going to be on the webinar, and I'll show her off. Her name is right here. It's not just because she's on the webinar. I was going to shout her out anyway. I talked to her before I prepared this talk for the conference, and she's doing a lot of work with trauma in CF. She's a pediatric CF social worker in Fort Worth, Texas, and she was doing a small study. She's probably finished that small study by now, but her long-term plan is to create an EMDR protocol specific to CF, similar to CF-CBT and acceptance and commitment therapy for CF, which to me is amazing. The idea that maybe sometime down the line, this will be available to people with CF the same way CF-CBT is available. I think there's amazing potential to make a huge impact in the community that way. So I think we should all support Rachel and her work. She's doing amazing work, and I'm really excited to see what she's going to do. All right, cognitive processing therapy is the next one. It is a form of cognitive behavioral therapy, which probably a lot of you are familiar with. It's probably the most evidence-based of any therapeutic modality, and we use it a lot in CF. And so it's CBT with a trauma focus, and the aim is to sort of change a person's understanding of their trauma, which reduces the symptoms. And, in typical sort of CBT style, the idea is you identify the automatic thoughts that are maintaining the PTSD symptoms. And I share this at the conference. If you're interested in really understanding CPT on a deeper level, there's a wonderful episode of This American Life called 10 Sessions. And it follows somebody, just trigger warning, she's a sexual assault survivor. And it follows her through her experience with CBT. And it's beautiful and really it's wonderful. So if you're interested in learning more about it, I highly recommend it. It's called 10 Sessions. It's episode 682. I looked it up for you all because I knew I would be mentioning it. So that should hopefully make it easier to find if you're interested. So example of a CPT session or several CPT sessions. If you've ever done CBT, this will look familiar. So, there's the education portion, which for me, I really like CBT because I'm someone who copes by like trying to learn a lot and like sort of intellectualize things. So the education section is usually pretty beneficial to me, but it's in the mental health world, it's sort of similar to the phrase name it to tame it. Like when you name something, you sort of identify it, it loses some of its power over you. So that's sort of the education symptom where you learn about PTSD symptoms, how your thoughts impact your emotions and behaviors. But with trauma, and for me, I had to go, a few steps beyond that. Intellectualizing it wasn't quite enough to process it, but that is a really important part of the treatment. And then, the next step is to identify the negative or distorted thoughts. Then you build your skills. So you can see a lot of similarities with EMDR. The steps are similar. And then the exposure section, which in EMDR would be the desensitization section, you confront the memories in a safe and supportive environment. You'll see that across all the modalities, including the emerging therapies. There's always some sort of confronting the traumatic memories in a safe environment. And then the last step is sort of restructuring, you're reframing your negative beliefs so that you have a more balanced perspective. So the last modality that I'll share is narrative exposure therapy, which is sort of a trauma subset of narrative therapy, which is a really beautiful, beautiful modality that I wish was kind of more available. It's not as commonly practiced as CBT and EMDR. And it's very similar to trauma narrative reprocessing, which if you read Body Keeps the Score, he refers to that a lot. And it's essentially the same sort of thing. And the idea with narrative therapy is that the stories that you tell yourself about yourself and your life influences your well-being. And so when your story is framed around a trauma, it's going to cause these symptoms that affect your life. So the concept of narrative exposure therapy is that you process the trauma within the context of your life story. And the goal, of course, is healing and resilience. So an example, multiple sessions of NET, it's, again, you'll see a lot of similarities, but the focus here is, so the sort of history taking part is, they call it storytelling. So you tell your life story, both good and bad, and then this helps prepare you, you process, make sense of your past, and then you sort of create a timeline with your therapist, focusing on the trauma, and then you revisit the trauma in a safe and supportive environment, of course. And then in the integration, you start retelling the story. You tell a different story. And then the last step is the empowerment. So feeling more control over your story and your past experiences. So, interestingly, I'm glad I made a note of this because I would have forgotten to say it. In the Body Keeps the Score, there's a whole section about therapeutic theater work. It's really interesting. It's not the kind of thing that's accessible to really anybody unless you're in a study with Bessel van der Kolk, I guess. But it was really interesting. So if you're interested in reading the book, I'll sort of call your attention to that section because, and sometimes you'll hear about people like doing improv classes, not because they're actors, but like for other reasons. And I think there is some sort of therapeutic process happening in that kind of work. So anyway, just a note, if you're interested in that, I think it sort of has, it's sort of adjacent to the whole idea of narrative therapy and storytelling. So if you're interested, I would encourage you to look at that from the book. So there is a lot of emerging research on psychedelic assisted therapies for trauma. And if you did see my talk at the conference, there are updates because things with MDMA actually changed quite a bit since I presented. Actually, even before I presented, I didn't check the news a few weeks before and there was an update, but now I've got all the updates. I have to give a disclaimer. None of these are FDA approved yet for trauma. So if you're interested and you want to talk to your CF team about them, we're not really in a place yet where your CF providers will be able to give you like a wholehearted, yes, it's okay to do this, because, the standard that we use in medicine for evidence-based, it just hasn't been, we haven't reached it yet with these therapies, even though they're being used a lot, sort of not officially in terms of like the medical world and the scientific world of evidence-based treatment. We have not met that yet. We haven't gotten over that bar yet. So, just take that with a grain of salt. At some point, I think some of these might be available in the mainstream and with all the safety that we need to be able to endorse something like this. But I do think it's interesting. And as I go through these three, you'll see the similarities with the therapeutic modalities, and the drug is sort of used in the reprocessing or the desensitization section of therapy. So I'll start with MDMA, which known by its street names of ecstasy or Molly. This one has been the most in the news and was sort of the furthest along in the process of the three, and now has sort of fallen back to the back of the line. So there are lots of different studies, but the one that I am choosing to sort of highlight is a clinical trial that was done at UCSF, showed really good results, no serious side effects. And they went before the FDA advisory committee in June of this year. And and then after the advisory committee, then it goes to the FDA, but the FDA usually follows what the advisory committee recommends. And it did not get through the advisory committee. There were lots of issues, and there's a bunch of articles in the New York Times. The New York Times has been following the MDMA thing pretty closely, and there's some really good articles. So please feel free to Google that and learn more about it. But when I looked in, knowing that I was going to do the webinar and we were going to have more conversation about this and my own personal interest, I looked at, did a lot of reading about what happened in June, and then again in August when they went before the FDA, and again, spoiler alert, did not get approval. So the FDA had concerns. Some of the health concerns they had were that there was elevated blood pressure, maybe risk for cardiac events, and then there were also some criticisms about the design of the studies that were presented. That first of all, the patients could tell if they got the drug or the placebo, which is pretty. That makes sense. It's going to be a hard study to double blind. And there was concern about bias from the researchers. And so then they went to the FDA in August, and they did not get approval. And the company that is trying to move this forward is called Lykos. And what I read in the New York Times article is that they're planning to ask for a meeting with the FDA to reconsider. A lot of people are upset about this. I think there was a lot of promise for this, and this feels like a huge setback. And there's a lot of controversy around it. I think it got a lot of media attention, which politicized it for the FDA, which can then influence decisions. So something to think about. But now people are thinking psilocybin, which I'll talk about next, is going to be approved before MDMA, even though MDMA was further along in the process. So that's the MDMA story. It is interesting and ongoing. So stay tuned. And then psilocybin is the next one, or known as magic mushrooms. Again, there's a lot of studies on the use of psilocybin in trauma. I just chose a few. One of them, it was an interesting one from South Florida, and it was with mice. And the mice that were given the psilocybin had a better overcoming of the fear conditioning than the mice that were given the placebo. And then a study from NYU. And there's also a similar one from Hopkins, if I'm remembering correctly, but it was terminally ill cancer patients. They got a one-time treatment with psilocybin, and they got very quick relief that lasted over 6 months in at least 80% of the people that did it. So that's quite promising. And then ketamine, which many of you probably know is an FDA-approved drug that's used for anesthetics, but it also has hallucinogenic properties, which is why some people use it as a party drug. Street name is Special K. And a lot of people are studying this, and actually some psychiatrists are actually using it in their clinics, sort of in a legit way. So I guess in some ways this one is further along, but it's still not, I don't know that it's actually approved yet by the FDA for use in trauma. But so there was a study on PTSD that one infusion of ketamine followed by brief exposure therapy showed really good results. And the results of that study, there was like a lot of brain stuff that was way beyond my understanding, but I included a quote from the study that did make sense to me. And basically it shows that ketamine has the capacity to help people rewrite their memories, modulate their fear response, which if you think about all the therapies we've talked about, that's the goal of all of them, is changing your relationship to your traumatic memories. So we'll see what happens with all of these therapies, if any of them, become approved and accessible to people. So, it's great that all these therapies are available, but as a social worker, a medical social worker, I know that, the therapies existing and being able to access the therapies are two very different things. So, just a couple of thoughts and tips about how to access these if it's something that you think you could benefit from. So, the first one, knowing is half the battle. So, you know what to look for. You can ask for these therapies by name. EMDR International has a find an EMDR therapist function on their website where you can look. There's actually quite a few. EMDR therapists are not that hard to find. A lot of people do it. And then CPT is an offshoot of CBT, so maybe easier to find. CBT is pretty commonly used because it's so evidence-based. Psychology Today, which is a search engine that you can use to find therapists where you can search in your area, by your insurance. They also have a trauma and PTSD search filter. So you can't filter specifically for EMDR, but you can filter for people that have a background in trauma and PTSD, and that might make it a little easier to find. Of course, don't hesitate to enlist the help of your CF clinic social worker. At my clinic, we have a community therapist that's trained in EMDR, is familiar with CF and lung transplant that we refer to quite often for people that need this kind of therapy. And she is very familiar with the CFRI counseling support program. So, of course, a plug for the CFRI counseling support program, because if you find a therapist, you can't find a therapist that's covered by your insurance, or you find someone that you like, but it's too expensive, don't forget that you can access the CFRI counseling support program and get 6 sessions for free. So the main message that I hope that you take away from all of this is that you can heal. Medical trauma is treatable. It's not something that is, you can heal, and I'm living, breathing proof of that. And so I hope that you can find what you need if this is something that you've been struggling with. So I won't spend a lot of time on this slide. It's my reference list. It's really small, but if you're interested, you can pause the video and look. There's some really interesting articles in there. Highly recommend the Tetris one. And now we will talk questions. And I just want to add that please feel free to email me if you have questions or you want to chat. And then, of course, you can always find me in the CFRI support groups if you ever want to join us there. So I will stop sharing my slides, Siri, if that's...
Yes. And thank you for reminding everybody this is being recorded. We are going to release this. Actually, it'll be available immediately on Facebook since we're streaming to Facebook Live. And then we'll also release it as a podcast so people will have the chance to play it, stop it, get whatever information they wish. But that was phenomenal, Kate. And we are all so grateful to you for bringing this to us. I have a list of questions, and I invite people to put any questions they might have in the Q&A box. But some of them you already, as I were looking at them, you answered on your own. One thing right in the beginning, you talked about, the many ways people have trauma, and obviously medical trauma, and that was the focus of this, but how medical trauma can be further triggered by pre-existing traumas in other areas of a person's life. And how would you recommend as a social worker that a patient, let their care team know? What is the best way to almost front load the team with that information so that the trauma can be minimized in advance?
That is a great question, which I would say obviously would vary by individual, but I think the sort of universal thing that is probably true for most people is you can identify a member of your team that you feel comfortable with. And that doesn't have to be the mental health professional. If you bring it up to a mental health professional, a social worker, psychologist, psychiatrist, of course, that's what we do. I would hope that any of us would respond positively. But, if you feel more comfortable with your doctor, with your nurse practitioner, with your RT, with your dietitian, whoever, I think, you can decide how much you want to share. You don't have to share all of the details, but you can say something as simple of, listen, I have a trauma history, and it makes me a little bit more reactive to things in the medical environment that might not seem like they're a big deal. So I just want to let you know, or if you know what your reactions are, you can share those. But really, it depends on your comfort level and just really choosing someone that you trust. And if you're not sure how it's going to be received, you can always say, like, I'm nervous to share this, but I think it's the right thing to do. So, and that sort of signals to the person that you're sharing with that you're vulnerable, which hopefully will give you a better likelihood of a compassionate reaction. So
The other thing was you mentioned, in that list of the many ways and causes of medical trauma, but intubation and hemoptysis, I mean, are two things that I don't think I have ever spoken to any person who has experienced one and sometimes both of those things that is still not dealing with the trauma of it.
yeah.
I'm just wondering with care teams, there's the spectrum, obviously, which is not to minimize how, a lesser dramatic medical trauma could trigger something, but for things like that, is there some automatic like red alert when that's happened to a patient? Some
Yeah.
strategy, I love that Rachel is coming up with this protocol, but something
Yeah.
automatically served up as an option or encouragement
Yeah.
to participate.
That's a very important question. And one of the parallels that I can give you with all of its problems is the stroke protocol at Stanford, which I'm sure is everywhere. I think it's a JCO thing that there's, after someone has a stroke, they have to do the social worker has to do a depression screen because there's some, association with stroke and depression. And the social workers struggle because it's mandated, which it should be, but at the same time, right after a stroke is not necessarily the time that someone is ready to talk about their mental health. And when I think about intubation, which I think in our world happens probably most commonly in the transplant context. And then if you think about recovery from transplant, or if you were sick enough to be intubated, you're not going to be, up and at 'em probably right away, ready to tackle your psychological trauma reaction. So it's very challenging because when your body is in survival mode, like you'll see a lot of this, like the approach to crisis response has really changed over the past 10 or 20 years. Like they used to send people in to debrief, and like now that's known, like it's not actually healthy to debrief right away, because people have to feel safety before they can start processing these things. So in my mind, the approach is, at least in CF, we have these smallish teams, people that know you. So if this happens to one of my patients, unfortunately, the way it happens is the transplant, I'm not as involved anymore. But if a patient that I know got intubated, at some point, I would use my judgment about the right time to talk about, give them some education, like in the CBT, the CPT model, educate them that this puts you at higher risk of having a trauma reaction that you might not even be aware of. And then really it's down the line that you probably are in a better place to address it. So I see where you're coming from, Siri. Like if it was clinically realistic to sort of address it right away, I think we would, but that's not how the brain and body are functioning when it's coming off of a crisis event. So I think actually, people in very CF community style, people educating themselves is an important thing. So the fact that we're talking about it in CFRI, we're doing this webinar. So now people with CF and their families know if something like this happens to me, like let's keep that in mind that this is especially intubation, especially hemoptysis. Like let's keep this in mind that this might be something that I need to think about later. And this is why I think when I finished the talk at the conference, a bunch of people with CF ran up to the microphone. I mean, like it was right there for them. It's like right there on the tip of their brains. I think people know that this is something that they are dealing with. If you think about our slide of our 55-year-old friend, like everything that he had been through, this is everybody, right, with CF in various degrees. So that was a very roundabout, non-answer.
No, actually, that was a very clear answer. I appreciate that. There's a question from Sarah. Are there any specific MTS-specific and validated screening measures or questions you would recommend to use in clinic? Typically using the PCL5-PC, but wondering if there's anything more medically focused to use.
That's a great question. I don't know. I would have to look that up, and I wonder if some of our other colleagues that are working in trauma, like I'm wondering if Rachel or any of the other people in CF that are working in trauma have recommendations, or I could even check with our psychiatrist. But we're always looking for validated tools, right? Because the screenings are nice because it's sort of a less threatening way to bring something out, for people that might be difficult to talk about. So that can be a homework assignment for me and for any of the other social workers or mental health people on the line that we can look and see if there are any trauma screenings. And I'll be totally transparent. We're not screening for this in our clinic. I mean, I'm pretty sure almost everybody has some sort of experience of medical trauma, but the question is it interfering in your life and your functioning? And would you benefit from more support? And the screenings can often help you figure that out. So great question. Sorry, I don't have an answer.
But oh my, do I ever want to do a study on medical trauma in our
Right?
community now? We need so much more information.
Yes.
So Sarah also has a question for children. It seems that child life specialists have great interventions to use to help in prevention of medical events being perceived as traumatic as they would otherwise. I'm wondering about how to incorporate these or adapt these for our adult populations as well. Any thoughts or recommendations?
Yes, it's a great point. And actually, at the conference, I co-presented with one of our child life specialists who covered the whole pediatric section. And then at the end, Devin, who many of you know, icon of the CF community, asked how can we get child life specialists for adults? Because but if you think about, so I have Sam's slides, but if I could look at them, like a lot of it is around preparation, education, and I think pediatrics is not perfect, but pediatrics definitely has more of a focus on spending time with the child, making sure the child feels comfortable. And the adult world is a little more like, let's move along, they're not as sensitive to adults. So I think, and when I think about some of the procedures and things that happen, these happen totally outside of the context of the CF team, So our ability to sort of educate and get to those providers without like really massive kind of reform and education, it's a huge undertaking, And so not that it can't be done. And if I was, in a different position in Stanford working on the whole enterprise, that would be something I would be pursuing. But what is within our control as patients or, people interacting with the medical world is thinking about those child life concepts, the education, the preparation, and distraction, things like that. And then advocating for yourself, like asking things to slow down, asking, okay, what's about to happen? Okay, listen, this has been really painful for me before. So can you take it slow? And the distraction is probably the easiest to translate, if it helps. Like, I still haven't gotten up the courage. I really hate dental work, and I haven't gotten up the courage to ask my dentist if he minds if I just listen to like an audiobook. Like, it's such a small thing, but I'm just like, I'm such a people pleaser. I don't want to be a bother. And sometimes they want to like ask you questions, but I would do so much better if I could just listen to an audiobook, just distract myself from it. But, and then, a lot of the, like the body scans and stuff that we do in adult, the guided imagery and that stuff can all be sort of translated to the adult world. But yeah, I think Devin put it best when he was like, why can't we have child life specialists for adults? I think we need.
Okay, I strongly encourage you to tell your dentist that you would like that.
I know. Well, now I called myself out in a public setting, so I'm going to have to do it.
That's right. You'll have to report back. But I think what's going to happen is they'll see your stress go down and they will start suggesting it to their other
patients. Yes.
Start the trend.
I don't think my dentist would care at all. Like why am I resistant to it?
I think we have time for one more question, and it is about what would you say to patients about getting over their fear? I think they're, for all of us, those of us who don't have CF, but to have, the black mark in their case file. And for people who are dealing with medical trauma, who are trying things like psilocybin or, Molly, how to be upfront with the care team and establish a place of safety and not judgment. I mean, I think, for obvious reasons, it's important to share that information, but for obvious reasons, there could be concerned that it's going to be, especially somebody looking at transplant, So what would you recommend?
It's really tricky. It's really tricky because, we as providers have to document, and medical provider. I mean, it's very relevant for your medical providers. Like, sometimes I'll have conversations with my patients, and if they ask me, or if I have my own clinical judgment that this is something that's better to not be in the medical record, I won't include it. And I feel very comfortable with that as a medical provider in a host setting, or a mental health provider in a medical setting, because if I was doing individual therapy, there wouldn't be like 600 people that could read my notes, you know? So having been a medical social worker my whole career, I've always been very careful about how I document for privacy purposes. So I am very comfortable talking about something like this with a patient and not documenting it. Medical providers, I can't speak for them. It is relevant. And, you know, it would have to be their decision if they felt like it was important to include it or not include it. But I have to be really realistic. And, you know, I don't want to scare anybody off, but I have to be very realistic in that any kind of substance use sort of counts against you in terms of transplant candidacy. And that's an oversimplification, but you know, it's true. And I understand why when people are sort of presenting for lung transplant, they want to present with their best foot forward. And there's, you know, these scores. It's complicated, you know, and I don't blame people for feeling, you know, not that comfortable discussing it if they are going to eventually have to get transplant. And some people are going to be very judgmental and you can't always predict. So, you know, I guess the strategy could be like, hypothetically, I've been thinking a lot about my own experiences with trauma. I know there's some therapies that are being studied that are not FDA approved yet. Do you have any thoughts? Just kind of a general hypothetical thing. But, you know, if you want to pursue one of these therapies, I mean, in a perfect world, I want you to talk to your doctor about it. But like I said, they can't necessarily advise you because these drugs are not yet at a place where there's enough evidence that they can say, let me look at this. I mean, there are studies, they could look at the studies, but it's still not FDA approved. And so we're in kind of a weird spot with it. And it was the same, it sort of still is the same way with cannabis. Even though cannabis is legal, there's not as much research as I think we all wish that there was on different things, you know, decades and decades of research that a doctor can say, oh, you know, edibles are okay, but smoking, you know what I mean? So, you know, I guess I think I'm giving a lot of non-answers. I'm sorry about that, but I want people to be really thoughtful about what they share and with who and why and what their goal is. And I wish that you could talk to your doctor without worrying about the consequences, you know, but that's not always the case. So.
Well, I will say that response is the perfect demonstration of why you received the CFRI CF Professional of the Year award. It is that sensitivity to patients and really an understanding of the broader scope of everything that adds up to CF care and all how the pieces interlock. So thank you. That actually was not a non-response, and you provided a way to open the topic. So we are coming up, actually, we just crossed the hour. So I do want to remind everybody, thank you for plugging the CFRI's counseling program. Also for, you know, as a person whose adult daughter has CF and has had multiple medical traumas, I really appreciated your recognizing that this medical trauma is not just about the person experiencing it physically, but for parents, how hard it is. So that's a great reminder that our counseling program is not just for individuals with CF, but also direct family members to avail yourselves of that. We will fund 6 sessions of therapy. Sadly, we can only cover $125 of that, but we are very open. Again, we have had people who, you know, it's a 12-session program. You know, at least we can cover, you know, half of those sessions. Some people already have a therapist, and yet we all know it's financially difficult. We can help fill the gap for those 6 sessions. So again, please contact CFRI if you are interested in more information. So with that, Kate Yablonsky, you are a hero to the community. This has been just
Thank you.
such an incredibly informative, helpful presentation. And I know I speak for everybody who's here today. We thank you. We are grateful.
Thanks.
All right. Thank you, everybody, for being here. Bye-bye.